Hi, welcome to iTech Training's COA prep course with Sharon Alamalhodei. I'm Sharon. Let's get started. Our first section is history taking. The way my course is set up is exactly like IJCAHPO lists the exam content areas. There's a main content area and sub-content areas. You'll also see a percentage at the beginning of each section. This is the percentage of questions that IJCAHPO says will be on the test from this content area. There's about 200 questions on the test, so that means you should have around 10 questions on history taking. At different points during the course, you'll see a gold starburst appear in the upper left corner of the screen. When you see this, this indicates that there's more information about this subject in your printouts. So make sure that you print out all your handouts and have them handy to refer to during the course. We gather the patient's history so that the doctor can come to a diagnosis. The patient will tell you what's wrong with them if you ask and then listen. I heard a doctor give a course recently at a IJCAHPO meeting. He said 60% of his ability to diagnose is based on the history, 20% on the exam, and 20% on ancillary testing. History taking is critically important. When taking a history, use your patient's own words. Don't substitute medical terms for the patient's own words. You don't want to offer any possible prognosis or diagnosis. Remember, interpretation of the patient's history is your doctor's job. Avoid irrelevant details and build upon their responses with pertinent follow-up questions. If the patient's a poor historian, don't tire them with an exhaustive history of present illness. Write down what you regard as their most serious complaint and move on. Your doctor can always expound upon the history when he or she sees the patient. If the patient's a poor historian, you can write on the chart, poor historian. The chief complaint is the main reason that the patient came in. It might be a new problem they're having, or it could be follow-up of a previously diagnosed condition. This should be brief, 1 or 2 sentences, and in the patient's own words. The history of present illness is detailed regarding their chief complaint. This helps the doctor diagnose and reconstruct the stages of the disease as it progresses. Don't copy forward previous histories of present illness. We use these descriptives that are listed here to construct our history of present illness. On the right are some sample questions you would ask the patient for these different descriptives. When all the extraocular muscles are working properly, the eyes will move smoothly and in unison in all positions of gaze, and the foveas will be aligned. Stereo vision is a high quality of vision that gives you three-dimensionality. If you're missing any one of these 3 things, you won't have stereo vision. You must have good vision in both eyes, the maculas must be projected straight ahead, and you need to have overlapping visual fields. Monocular patients can have depth perception, but they do not have stereo vision. Versions are binocular movements of both eyes in the same direction. Supraversions looking up, infraversions looking down, dextroversion is looking to the right, and levoversion is looking to the left with both eyes. We also have cycloversions, which are rotational movements of the eyes. Ductions are monocular movements. Abduction is looking out, away from the nose. Adduction is looking towards the nose. Supraduction is looking up, infraduction looking down. And then we have cycloductions, which are rotational movements of the eye in or outward. If your patient's versions are full and they do not have complaints of double vision, you're done with ocular motility assessment. But if their versions are not full or they have complaints of double vision, then you need to do cover testing. I'm going to teach you two cover tests now. The first is the cover-uncover test. In this test, we have our patient look at a small distant fixation target. I'm going to cover one eye at a time, and I'm going to look at the uncovered eye. If I see the uncovered eye move, I have found atropia. So let's go ahead and do that on my patient here. This is my patient Abe. So I want you to look at a small distant fixation target. And here I'm just going to cover OD 3 times while I look at OS. So I cover, then uncover, cover, then uncover, while I'm looking at the left eye. You don't want to rush this test. This is a good pace to do it. Make sure you're occluding the eye completely so they can't fixate around it. And the left eye is not moving. So he does not have atropia on the left side. Okay? Now I am going to test for a right tropia. And so I'm going to do the same thing, but now I'm going to cover the left eye. Now I'm going to be looking at the right eye. I do not see the right eye moving. So he does not have atropia in either eye. The refractive state of the eye refers to the eye's ability to bring objects into focus on the macula. Emmetropia means the patient has no refractive error. The light rays come into focus right on the macula. Most people are not emmetropic. If you say someone is ametropic, that means that they have some sort of refractive error, so it's non-specific. 3 types of ametropia are myopia, hyperopia, and astigmatism. Myopia occurs when the light rays come into focus in front of the macula. This occurs either because the eye is too long, or the cornea is too steep, or both. Hyperopia is when the light rays come into focus behind the macula. This occurs either because the eye is too short, or the cornea is too flat, or both. Astigmatism can be due to the cornea or the lens. And astigmatism is where there are 2 focal planes formed in the eye. When I say focal planes, I'm referring to lines of light as opposed to points of light. An eye that has astigmatism has 2 focal planes, which are typically separated by 90 degrees, and one or both of the focal planes are not on the macula. Let's talk about refracting with the manual phoropter. Here are your parts of the phoropter. Make sure that you know all these parts for your test. Now, we have a level indicator. Do you know why it's important to level your phoropter before you begin refracting? It's so that your axis is accurately represented. If your phoropter is tilted by 10 degrees and you dial in the axis 180, you're not accurately representing the axis 180. So make sure that you're leveling your phoropter before you begin refracting.